The College of Public Health Poster Day marks the completion of each Masters of Public Health candidate's capstone project. MPH candidates gather to present their projects to advisors, faculty, and guests of the university. Here's a small sampling of the 2016 MPH presentations.
My research project was reviewing drought plans for the nation, state drought plans, to see if we are talking about the health consequences of drought. So I actually did the data collection, and I went through the drought plans. It's really important, especially in the West, where they're now seeing more frequent and severe droughts. These are the things that you're going to start seeing and people are actually going to feel, as opposed to just going outside and it being dry. This is people losing their jobs and having mental health effects, and being prepared for that will help us mitigate the problems ahead. My findings are drought plans do not talk about health in general. About a third talk about health to an extent, or at least mention one health outcome I search for, but the rest of them do not mention any. My plans currently are to apply for jobs. I did my internship at the CDC, so I'm applying to ORISE fellowships there.
With the new election coming up in November, I decided it'd be interesting to look at whether health outcomes can affect voter results in counties, particularly since there's a whole discussion around whether the new healthcare law that came out in 2010 should be repealed and replaced with a new one or expanded. So what I did is I looked at the 2008 presidential election, and I looked at the voter results as my outcome between Democrats and Republican. And I used a predictor called years of person life lost, which looks at premature death per county as my predictor. So years of person life lost is a good way of seeing where counties have a lot of health problems for younger populations. So what I found out was that those with a high YPLL were 1.5 times more likely to vote Republican in that election than Democrat, which was interesting because it kind of showed that those with counties that are unhealthier, had higher mortality rates, were more likely to vote Republican. So it was a larger study, it was an ecological study, so it would be something that I need to start controlling for different variables. So I didn't control for socioeconomic factors, age, county population size was a big one, so whether rural counties are more likely to vote Republican or Democrats. And with that I thought there are more counties that vote Republicans, but since the counties that vote Democrats have a higher population, they kind of skew things around. So I wanted to control for those in a future study. And also look at different health rankings as well to see if there's kind of variation between other factors as well. Both sides say that their philosophies are more likely to have better health outcomes for their constituents. So it's important to see, are the actual philosophies even working really well, or is there changes that we need to be making to making the health outcomes better for those populations? I continue doing research with Emory University, working on an HIV study, and I'll continue doing my health coaching with the YMCA for a diabetes prevention program. And then I'm going to be looking for a full-time job, hopefully starting in August.
So my research project is the ecology of Listeria species in a dry food processing plant. We took samples from one dry food processing plant in Atlanta, Georgia, and we went there 4 times. They were all environmental samples, so they were collected from floors, drains, equipment area, and the steps. So we had 2 step locations. When we go out, we use this little sponge stick here to collect our samples. And each time that we collect a sample, we aseptically, so we don't contaminate, put them back in and store them until we take them to the lab where we process them. We have a 5-day processing where we grow up the bacteria, identify what's present if we can. If it was Listeria, we would store it for whole genome sequencing. Our results found from 12 of the 29 locations, there was Listeria found at least 1 time in an event. We found it in the yellow pole base here, which is an equipment area that is used to prevent forklifts and different mobile equipments from bumping into the wall. So this yellow casing is able to be lifted up, and so there is often underlooked, and so you could recover bacteria from there. We have 3 times of the 4 sampling events. Our recommendations to the different dry food processing plants is to do a routine environmental sampling of their plant. This will alleviate or curb outbreaks from potentially happening. So if they found these areas positive for Listeria, they could prevent it from causing a potential food outbreak. So Listeria has about 7 different species, and one of them, Listeria monocytogenes, is pathogenic to humans, so it could cause illness in humans. And more specifically, those populations it affects is pregnant women, the elderly, young children, and immunocompromised. So if you're really sick, you can potentially get it. But it also has affected healthy people. It just depends on the dose amount that is in the food that you're consuming. After graduation, I'll be working with the USDA here in Athens in egg safety and poultry.
Well, I actually did a project on emotion dysregulation, sexual risk behavior, and social support in a group of urban, adolescent, and young adult couples. We actually looked at whether their introspection and awareness of their own emotions, the management of their emotions, and how well they were able to express those emotions impacted their sexual risk behavior. And we found out that it did. The less you express your emotions and the less you're able to be aware of your own emotions, the more likely you are to engage in risk behavior like transactional sex, multiple partners, or having sexually compulsive thoughts that disrupt your entire life. We actually did a study that looked at the individual partners first, but then I realized that to look at a partner that's in a romantic relationship, you needed to look at how their romantic partner kind of influenced their behaviors with their own. So we did multi-level actor-partner modeling, and that actually helped us find out whether your partner's emotional expression might impact your own behavior or whether their emotional expression or lack thereof would impact your sexual behavior. And we found that that was pretty significant as well. The data comes from data from a study that's called Partners in Life. It's actually through the Yale Research Group at their School of Public Health. It is a couples intervention that helps young couples that have a small child actually improve their relationship functioning and their parenting. It's a lot of computer modeling. Well, we actually do dyadic analysis, so you use statistical analysis and you can look at members as either a couple or an individual. So you run some statistics and then you get your output. That's pretty much it. Well, I'm actually going to be going back into science. I'm a molecular biologist by trade, and I came to health promotion to learn how not only your genetics and scientific data, but your social status and your social determinants of health can actually impact your physical health. So I'm going to be going to get my PhD in pharmacology and toxicology, and I hope to make sexual health, and especially contraceptive access, more accessible to low-income minority communities.
I looked at employee assistance programs and their return on investment in depressed employees. Depression is the leading cause of disability worldwide, and it also has the biggest impact on job performance. So they're looking at a way to kind of combat depression at the workplace and not having to rely on people seeking their own care. My findings were that employee assistance programs have a very good return on investment, and when you put in salary but also benefits, that you can see up to 647% return on investment, which is very promising as healthcare costs continue to rise, but we want to be more efficient with healthcare. I did a literature review and I looked for literature that used return on investment but the correct calculations, because there's a lot of calculations out there. So I looked for ones that use standardized calculations that are accepted by a lot of economic evaluators, and from there I was able to put in their costs, recalculate costs, and bring them to present value to just figure out what the ROI was and make sure that it was the same across the board. Implementing these programs at $24 to $25 per person per year is very beneficial, and that they should look more into this instead of kind of pushing it to the wayside. So after graduation, I have a job at Willis Towers Watson. I'm going to be a senior healthcare analyst.
So my poster presentation is basically an overview of what I did in Africa. I was in Cameroon for 3 months conducting field work with peer educators and psychosocial counselors. And our peer educators take the role of a female sex worker. And so what I did was I basically shadowed their outreach strategy methods, and just to see an outreach strategy as to how they collect clients into the system. And what we wanted to implement is a mobile technology, a way that we can implement an outreach strategy that can track a client and monitor a client, so we can kind of figure out when was their last time they came for an HIV test, and we can follow them up and see if they need their ART medication, and we can also just send them a text message reminder. So mobile technology it's a really cool and neat way to track clients, especially clients who are from the target population, like a female sex worker and MSM. Because these two target populations are illegal in Cameroon, they take the risk of being exposed when they go into a hospital or where they go into a drop-in center that's not really friendly. And so what we want to do is basically be able to communicate with them via text message, just to let them know that, we're thinking of you, we're reminding you when your appointment is, and we're reminding you of when you need to take your medication. So doing this can kind of like establish a more friendly relationship, and so they feel like they have someone who's with them the whole time that they're going to the system. In 2011, the HIV prevalence among MSM was 44.3% in Yaoundé and about 36.9% for female sex workers. So key populations have a high burden of HIV because it's illegal, and it gives them a chance to kind of keep it in the low and not really want to be open with their status. And because it's criminalized, it puts more of a burden on their shoulders because they don't know which avenue to go to. So that's why we want to implement a strategy for them to know that they have help and that they're being reminded by a text message. After graduation, I will be sitting on my computer and applying to hundreds of jobs and applications and crossing my fingers. And hopefully my goal is to be able to find a position within the international development field. I would love to go back to Cameroon or back to Africa. Specifically, I would really, really love to work for a nonprofit organization like CARE that's focusing on international health.
The effect of conflict on immunization campaign effectiveness in northern Nigeria. We went to northern Nigeria, and I was working for the core group Polio Project, and we were helping them with their midterm evaluation. So the midterm evaluation was just focusing on program effectiveness and the reach of the program. They work in 5 troubled immunization states in northern Nigeria, so we broke those up into conflict states, which is Borno and Yobe, which has Boko Haram heavily involved, and non-conflict states that don't have Boko Haram, which is Kano, Kaduna, and Katsina. And what we were looking for was the differences in immunization rates, the differences in education of women, access to health care, access to vaccinations. And so what we found was that in conflict states, the immunization rate was significantly lower, almost half as low as what it is in non-conflict states. And as well as women have less access to education, they typically only attended Quranic school, whereas non-conflict states, they attended secondary school, which is sort of our equivalent of junior high or high school. And what we also found was that in conflict states, they had to walk at least an hour by foot to the nearest place where you could get some vaccination or access to health care. And what I recommended was they have cold change, which are vaccine centers where they keep vaccinations, and they're able to keep that there and have it solar powered, so that one of the problems is there was no access, we couldn't get in. So having that access and having the ability to have vaccines there all the time is important. We also wanted to help with a social behavior change campaign to increase access to education for women in conflict states, as well as give them more autonomy over the health care of their children as well as themselves. Polio is just recently been taken out of an active state in Nigeria, but it's really fragile. There's still a 2-year wait before they can officially say that there's polio free. And as well as you can see, 10.5% in conflict states for immunizations and 18.4% in non-conflict states. Those are really low numbers. So a number of children are not getting vaccinations that can prevent them from childhood diseases, communicable diseases that are preventable. Polio being the one that's the biggest problem at the moment. There's only 2 states left. It's Afghanistan and Pakistan, and Nigeria just, when I was there in July, got off that list. And they can easily get put back on it. And they were responsible for all polio. So the Nigeria virus was responsible for all polio infections in Africa for years and years. So getting that and getting these programs, getting access to polio and getting access to education for women and getting access to having vaccines and having hospitals and workers there really helps boost the immunization rates in those areas. So I got a job with Catholic Relief Services, the group that I went to Nigeria with, and I'll be moving to Cairo, Egypt in August.
My project was looking at the perception of mental health providers in using the system of care approach to mental health treatment. The system of care approach was introduced in 1986, and it hasn't really been widely used within the state of Georgia. I interviewed 20 mental health providers and also identifying the stage of change that they were in. The providers mainly identified that they knew what system of care was, but at the same time, there were different challenges or gaps preventing them from applying the model. And there were mainly three. One of them was communication amongst the mental health providers, and then the second one was collaboration amongst the systems within Clark County. And then the third one was funding, which was a big deal because everything around mental illness treatment rotates around having billable hours. Now, with my project, this is just the initial stage of it. My interviews were at 4 different community meetings. And the last big one was at Oconee County Veterans Park. And the next one is coming up in July. And in July, we'll be reviewing what I've done and looking at ways of how to move forward. Ways to move forward, like educating the mental health providers more on the system of care, and then also identifying how the different systems can work together. My take-home message for my project was looking at how mental illness affects not just the individual, which means we have to transition from looking at mental illness as an individual problem, but look at it as a public health issue that needs community involvement. Actually, after graduation, I'm excited that I recently got hired by Advantage Behavioral Health to work as the Zero Suicide Program Supervisor for the Garrett Lee Smith grant that Advantage was awarded. So I'm excited to implement that in Oconee County. And it's Oconee County because the recent years, Oconee County has been the highest, unfortunately, in suicide rate. So I'm looking at building a coalition in Oconee County and educating the community more, especially those ages 10 to 24, on ways of assessing and identifying any risk factors, or looking at the school system and how they can identify some of the issues that the students are going through to help reduce suicide rates.